Monterey County Emergency Medical Care Committee. This is a joint meeting also with the CCC and Ops committees. Just for purposes of making the meeting flow smooth, what we're going to do is we're going to do roll calls for each respective committee, and then after that we'll do introductions with other participants in the meeting. So with that, I'd like to ask Steve to do a roll call for the EMCC.
All right, good morning, everybody. EMCC roll call, Will Hiller.
Here.
Sam Klemick.
Here.
Jim Lineborg.
Here.
Harry Robbins.
Here.
Jody Schaefer. Nancy Utterback.
Here.
Paul Wood.
Here.
Nick Greenson.
Here.
Oh, wonderful, thank you. Impeccable timing. Spencer Harnett.
Here.
Carla Spencer.
Here.
Jeff Watkins.
Here.
John Anthony. Let's see. That's ex officio members, Kelsey Scanlon. Teresa Rios.
Here.
Leanne Magoski.
Here.
Any alternates who would like to introduce their presence?
Mike Eslinger with AMR.
You? Mike DeLeo?
Mike DeLeo.
Cheryl Getz, did you join online? Here, Ben Harvey, Noah Hawthorne. Joe Kafar wasn't going to be here, and Bandy. Okay, that's MCC.
Okay, this time I'm going to yield over to the chair of the CCC to allow you to take a roll call and open your meeting.
Okay, thank you. And so we'll take a roll call for the CCC Clinical Care Committee, newly named. Steve, do you want to go through a roll call for CCC?
I can get that, Dr. Brewer.
Okay.
Dr. Michelle Polinsky. Here. Dr. Noah Hawthorne. Dr. Derek Orchard.
Here.
Dr. Nicholas Greenson.
Here.
Philip Brown.
Here.
Jamie Tovar. Cassie Caldera.
Here.
Carrie Campman. Spencer Harnett.
Here.
Carrie Campman's here, sorry.
Thank you, Carrie. Justin Reyes.
Here.
Josh Savignon.
Here.
Ben Hitchcock.
Here.
Jeff Horner.
Present.
And Jeff Watkins.
Here.
And for the alternates, Dr. Reb Close. Dr. Brian Darger. Dr. Cole Click. Dr. Ian Stamer. Christy Soboleski. Michelle Villanueva. Chelsea Metler. David Thompson. Rachel Nealon. Christopher Kuzner. And Christopher Borkin. Here. That's
Okay,
everyone.
at this time, I'd like to yield over to the Ops Committee Chair to open your meeting and obtain a roll call.
Obtain a roll call for the Ops Committee.
I'll do the roll call. Captain Scott Houchin. Sheriff Tina Nieto. Cassie Caldera.
Here.
Will Hiller.
Here.
Chief Justin Reyes.
Here.
Olivia Madrigal. Jeff Horner.
Jeff Horner present.
Spencer Hartnett.
Here.
Captain Ryan Alexander.
Here.
Mike Eslinger.
Here.
Sorry, Ryan Alexander present.
Leanne Magoski. Here. And Christopher Kuzner.
Okay, this time we'll go ahead and we will do introductions of participants.
For anybody who has not already attached themselves to a committee, this would be a time, if you wish to do so, to let us know that you're here.
Monty Moose Jenkins, stroke coordinator at Salinas Valley Health.
No other introductions. And we will go ahead and open up to public comment.
I have a comment. I started a scholarship program at MPC for the EMT program. It's going to run for 5 years and help students. I gave them $10,000 and it is now in effect.
Any other comment? Any comments from Zoom? Seeing none, we'll move on to item number 3, approval of past meeting minutes. There are none. So we'll go ahead and move on to item 4, reports. Again, no reports. Item 5, old business, there's none. And we will move on to new business and item A, CSA 74 disbursement. Karina Moreno, do you have a staff report for us?
Yeah, hi, good morning. I will pull up the CSA 74 allocations for fiscal year 23-24. These allocations will be dispersed in December of this year. Give me 1 moment to bring it up. And a small, larger. And it's still small, so you know what I think I'm gonna do, I'll switch it to the year-to-year comp where I can a little better to see the difference. Is that better?
I can see it. So thank you.
And these, I believe have been made emailed to you guys. Steve, is that correct? In the agendas or not? Okay, if you want me, I can have Steve email them to you.
Karina, could you talk just a little louder? I'm having a really hard time
Yes, and
hearing.
if you guys want, I can have Steve email them to you, or I can email them to you myself.
And if I may, Chief?
Please.
So as everybody knows, there's the calculation of the CSA 74 follows a prescribed methodology. We have a year-to-year comparison just to watch for any major fluctuations that there might be. The methodology includes everything from the workload, which is the emergency medical calls for each of the jurisdictions. It takes in consideration population, and I'm blanking out on one more item that I think it includes. All of that gets dumped into a formula that's already prescribed, and that's how the distribution happens. We'd like to show you the year-to-year table. So you also with the column that shows the change from prior years, so you can see that that there are no major variances in the distribution of these funds. And we would seek endorsement from the committee to move forward with the distributions, which according to the MOU, we need to make those by the month of December.
So do we have a motion to approve CSA 74 disbursement?
So moved.
Second. All right, and take a quick roll call on that one, Stu.
Okay, roll call to move to proceed with CSA 74 disbursements as as shown up here on the screen. Will Hiller. Sam Clement.
Aye.
Jim Lamborg.
Aye.
Harry Robbins.
Aye.
Nancy Etterbeck.
Aye.
Paul Wood.
Aye.
Nick Greenson.
Aye.
Spencer Harnett.
Aye.
Carla Spencer.
Aye.
Jeff Watkins.
Aye.
Motion carries.
Very good. Moving on, item B, ambulance RFP scope of work draft. And we'll go ahead and we'll turn this over to Teresa and her staff.
Thank you, Chief. This is an item that everybody has been very interested in seeing. We thank you for such a great turnout to this meeting and your commitment to this project and being here on this day. We have prepared a PowerPoint presentation just to go over the process of the RFP and to talk about our system and what we are doing in terms of the scope of work, some items that we want to highlight, and then provide an overview of the steps moving forward, and then open it up for discussion by the committee. Deborah Hopgood is going to be presenting with me. I also want to announce that, today with us, we have our health director, Elsa Jimenez, and also Susan Blitch, our county counsel. We're very happy to have him in our meeting today as well. Corina is going to set up the PowerPoint.
We're pulling it up right now.
Thank you. Thank you. So again, the purpose of this presentation is to provide background information about the RFP process in the ambulance services in Monterey County and how we have used that to in the system design for the next ambulance contract. Next slide, please. So a very broad overview of the RFP process is, the EMS agency in our role as the lead enforcement agency for the County of Monterey. We are responsible for establishing the exclusive operating area for the county through a competitive process. This competitive process is strictly overseen by the county contracts purchasing department, county council, in the emergency medical services authority, which is the entity that oversees all of the LEMSAs across the state of California. Together, these three groups make sure that we comply with purchasing policies and other requirements, laws, regulations, local ordinance, and to ensure that the process is fair and objective and free from any undue influence. What is key to point out is that the EMS authority reviews and approves the RFP process in the RFP so that the EMS agency can secure 1797.6 state antitrust immunity. That means that before we can release the RFP, the EMS agency has to obtain the authority's approval for the release. Next slide, please. Okay. So Monterey County, we all love the county where we live, but what we do have some realities that we need to face is that the County of Monterey has a very large geographic area. You can see the map on the screen is the map of that we currently use in EMS, and the different colors show the different areas that also have specific response times in the county. What we know is that large portions of the county are sparsely populated, and we do have areas that have single road points of access. Next slide, please. The payer mix specific to emergency medical services, we're looking at the payer mix for the County of Monterey. We have a high percentage of Medi-Cal and Medicare patients, and we also know that Medi-Cal and Medicare reimburses at lower rates. You can see the table there. We are doing a comparison with 2019, which is the pre-COVID year, and our Medi-Cal Medicare comprised 67.3% of the payer mix. And by 2022, that went up to 71%. And then you can see the private insurance and self-pay from 23.4% to 21%. So, that shows us that we have a lower private insured, and this impacts the reimbursement rate for an ambulance provider. Next slide, please. Okay. So in our the services that are provided under the current agreement, we monitor those, and we are constantly looking at ways in which we can improve which means that we can change those system changes and turn them into a system design for the next contract. What we are looking at here is that in the county of Monterey, in terms of our response times, we do have urban response time standards in a mostly rural county. We have services that demand the system needs, but when we look at them, we see how they impact the system. We have a requirement for a 24-hour ambulance in Big Sur. And we also have critical care transport in the county provided by the ambulance provider. The table that is shown on the screen is showing the data from 2022. And just so you can see, compared to the overall call volume, what CCT and Big Sur call volume and number of transports are. We do need to point out that the 68 transports for Big Sur, we really were looking at the area of Big Sur. However, the ambulance is able to provide other transports in the area, so that can range from 68 to about 100, and is similar with the CCT transports. But we really wanted to stay consistent and pick a place where we could actually be better for us to manage the data. We also have out-of-county transports. We know that for out-of-county transport transports of behavioral health patients, those are challenging. There are needs of the patient that need to be met. There are needs of the hospitals that need to be met. What we know is that the landscape from the time that this contract was awarded back in 2010, the landscape of the facilities that accept patients who need ongoing care for this behavioral health patients has decreased in years. And what we find is that patients have to go farther and farther away. Hospitals have the challenge of securing those beds and needing the patient to get there as quickly as possible so that that bed is not given to another patient. So there are some challenges there. And then we also have in our contract coverage for special events and other unplanned events like the wildfires and standbys. All of these are needs of the system. They have to be met, and it is the EMS agency's responsibility in our role as the lead agency for the county to work with our stakeholders in crafting a scope of work that balances all of these needs. And sometimes there are needs that pulls us in different directions. Next slide. Okay. What also we have in the current contract is that the provider is not able to bill or give reimbursement for calls that do not result in transport. We also deal with a cost of living for the county of Monterey. They can be higher than other places. It attracts many, many people who want to be here. And we also know that the contractor provides its own dispatch services, which of course adds to some of the cost of providing services in our county. Next slide, please. So for the next ambulance services agreement, we must address the needs of the patient, the changes and challenges in EMS systems and healthcare. Those changes include, but are not limited to the EMS system financing and reimbursement, evidence-based patient care changes, technology advances, which can work to our advantage, call volume changes that we have seen fluctuate, particularly during the time of COVID, and regulatory changes that are happening. We also have to face some of those local system challenges that we have described. Next slide. So what have we done to prepare for the next RFP? It starts with our ongoing oversight of the system. With a focus on system quality improvement. That happens through direct community input and feedback. A lot of the discussions, meaningful discussions that happen, they have led to system changes have happened in these committees through EMCC, the new former MAC, new CCC ops, and even our quality improvement committees through CQI TAG, STEMI, stroke, and trauma. We also have some direct collaboration with stakeholders. and administration of the current ambulance services agreement, having a close eye on the performance of the current provider gives us a lot of information from which we can bring improvements to the system. And I think you will be able to see those in the next few slides. We conducted a SWOT analysis to gather additional information from our stakeholders. If that was sometime in the summertime. We have worked with hospitals to explore solutions to issues unique to them. We just mentioned that behavioral health and CCT patient transports. We have reviewed recent RFPs conducted by EMS agencies in other jurisdictions. We have sought guidance from the EMS authority, and we obtained technical assistance from a contracted consultant. So in preparation of this RFP, what we needed to keep in mind is that there are things about the way things are that we cannot change. We cannot change our geography. We cannot change the payer mix. We cannot change how medical or Medicare reimburse for services and the rising cost of providing services. So how do we manage all of that along with the demands of the system, along with the needs of the patient in order to bring the best contract we can bring to the system? Next slide, please. And I think at this time, I will turn it over to Deborah.
Okay, sure. As we approached writing the draft scope of work, we had three major points in mind. The first one being collaboration with the stakeholders during the lead up into the issuance of the RFP. The second being innovation. The draft scope of work requires that the proposers demonstrate a past and future commitment to ongoing innovation in EMS system quality improvement. And then also the triple aim in healthcare. So enhancing patient experience, improving population health, and reducing costs. And we think that these concepts are interwoven throughout the fabric of the RFP, and that you'll see them as you review the scope of work. So far as the draft scope of work, we're going to go over some different areas of changes. These are kind of general changes that are integrated into the scope of work from either the current system or from the current RFP, the last RFP that was issued. So one is streamline languages. We've done a lot to go through and cut down excess requirements, excess language, just kind of streamline the entire document into a smaller, more manageable package. We've also integrated our current response time measurement criteria into the new RFP, and we've increased the length of the contract term from 5 years to 7 years, and there is also an option to extend for an additional 5 years. There can be a large startup cost associated with initiating an ambulance service, and we believe that this gives the provider a longer chance to amortize those costs and kind of a guaranteed time that they will be in place as a provider. So next, we've also worked to reduce costs associated with running the EMS system and then increasing revenue as well. We've relaxed some requirements related to management personnel. And what we mean by this is that the previous RFP had prescriptive titles for different positions. And oftentimes those titles will come with particular expenses tied to them. So rather than do that, we have described the services that we need that particular role to provide, and will allow the provider to identify the personnel that will best fill that role in their particular structure. We're also not requiring a brand new fleet. This is a big step to reducing costs. There are also considerations in the difficulty to obtain ambulances after COVID. Many people are seeing long delays when they're trying to obtain new apparatus. We've also placed reporting requirements and standards in the scope of work to ensure that ambulances are in good operating conditions and that there are provisions for them being taken out of service should there be issues with the operating condition with particular ambulances. We've removed requirements for the service provider to obtain various accreditations. And again, this isn't related to the personnel in the field, it's related to the agency itself. So things like CAS or ACE Center of Excellence for Dispatch, we've taken those out of this current RFP. We feel that through managing our interactions with the agency, the provider, through our policies and procedures, and through our contract oversight, we can accomplish many of those same goals without tying the expense of actually going through the process to obtain those accreditations. We've lowered and eliminated some liquidated damages. There is a provision to allow the provider to bill for certain non-transport services. And then we are allowing proposers to potentially subcontract for out-of-county interfacility transfers and then propose ways that might be unique or might be a revenue or an expense saver to provide CCT services and Big Sur coverage. So another area that we've really worked on is increasing resource utilization efficiency. This is a thing from our current contract in that we will allow the use of basic life support or EMT staffed ambulances to cover interfacility transports. This frees up our ALS resources for higher acuity calls and calls within the 911 system. We've also taken steps to refine the medical priority dispatch system usage. So we want to better triage our calls to make sure we get the right resources to the calls when they occur. And this also gives us the opportunity to reroute units to higher priority calls that may come in. And then we've also made efforts to reclassify calls into the correct priority. And an example of that would be the work we've done with unconfirmed medical alarms.
Can I ask a question? Real quick, so the graph on the right there, so our number of behavioral health transports going out of county is decreasing?
Yes, it actually is.
Oh,
Yeah, yeah, that's the latest information through October 20th. So,
okay, great.
yeah, absolutely.
And that is directly related to the work that we've done in the administration of the contract in talking with our hospital the stakeholders. The last bullet, which sorry, Deborah.
No, go for it.
That we work with the ambulance provider to ensure that the correct documentation is obtained when a facility is requesting an out of county transport, and to ensure that that we are adequately using an ambulance resource, then to provide it's called a TCS form that provides a medical necessity justification. So that, in combination with other efforts that AMR has put into this, you can see that it's paying off. The out of county transports, which are very resource heavy, the provider can go as far as San Diego, Santa Rosa, Bakersfield, other places, but let's just talk about a trip to San Diego. They can put a unit out of the 911 system for a whole day with a crew of 3 individuals. Michael, correct me if I'm wrong. Yeah, and that's just them doing a turnaround, not staying, resting, and coming back. Is that correct?
Yeah.
Okay. And so we needed to think about those circumstances for the staff as well who are having to do to make those trips to San Diego, which may not be as often as other transports, but they're very resource heavy.
I'm confused. You're saying that that's the source of the large drop of transfers out of county? Because
No. We're not saying that there are other factors.
I believe,
involved.
Nick, what you're basically what you're asking, we have patients that stay in our department for a week. The fact that we're serving as a crisis stabilization and prolonged state unit, we're able to stabilize patients that would have traditionally been transferred out of county.
Oh, you think that's what it is? Okay.
Yeah, because we can no longer get transfers effectively done.
Okay.
So
maybe it's not
I
quite
have
the
an
way we were
entire wing
hoping
of
for.
the emergency department that is dedicated towards mental health care
Okay.
and holds, and this is related to inefficiencies of the system that don't allow us to get out, not just the EMS system, but the healthcare system as a
Right.
whole.
Okay, yeah, because there's a major,
So we're
obviously-
able to put people on long-acting agents and stabilize them by utilizing emergency department
Okay.
resources, which then affects the system in other ways. It's obviously very suboptimal,
Okay.
but we can drop our transfer substantially because of that.
Okay, so no parade.
No parade, wish there
Okay,
was,
right.
but no, mental health crisis is huge
that's
in
what
this
I thought.
country.
Right.
It's out of control, and yeah,
Okay.
emergency departments are taking the brunt of
Right,
it.
that's why the graph didn't make sense to me when I asked the question.
No,
So I was like,
that's why I'm
this is not my
clarifying.
experience. Okay, right. Never mind,
Yes,
sorry.
it's
Didn't mean to
not.
derail the RFP process. here.
Sorry.
Go ahead.
Right, no, and what that means is that we also, what the point of that is that we've worked on ensuring that when the resource is requested, it is a resource that is needed to meet your needs. And not just, there were instances where requests were being made for an ambulance resource that wasn't necessarily the most appropriate resource to be used. So that it can be available for the behavioral health patients who really need it.
And then the other question, the transports in the graph, that's what AMR is doing. Have the other providers, remember we were engaging other providers to make transports? Are they
Yeah,
making
no,
transports or what?
That was not put in place. AMR continues to be the provider. And we have done other things to make sure that we are in better communication with the hospitals. I think that communication and education as things are happening in the system are really important. There are times that it is challenging to get a resource to the hospitals when there are multiple requests for a behavioral health transport. Sometimes we've seen in the system up to 3, 4, even 5 requests for a transport around the same time. So how do we balance all of those needs? So we understand that patients do sometimes wait, or a lot of the times more often than we want to wait, but we are managing the resources better than we were before.
All right, I want to circle back to one point related to MPDS before we move on from this slide. The EMS agency has made some efforts, as I was mentioning, to improve the use of MPDS over the past couple of years in particular. When we started working on this project, we were seeing about 50% of calls go through the MPDS process. We're now up to 70%, with about 4% having help arrive prior to the dispatcher completing the process. So we feel that that's a significant chance to prioritize those calls appropriately and make sure we get the right resources to those calls in a timely manner. And next slide, please. Another priority area that we worked on were the clinical care related components. So we do require the proposers to demonstrate that they have a track record of clinical innovations and to describe those innovations that they've made over the past time period. They're also required to submit a plan to orient personnel to operations in Monterey County. And this is because we want to make sure that if we're bringing in new personnel, that they are ready to hit the street on day one and provide the highest possible level of care to the people of the county. The new RFP scope of work also requires EMTs to be trained at the expanded scope practice level. This adds a couple of items beyond the EMT regular scope. So that would be placement of supraglottic airways and then the use of CPAP devices as well. One of the big changes is implementing a clinical scorecard system. So this establishes key clinical performance indicators, or KPIs, that we believe have a direct impact on the health and safety of patients. In order to be a KPI included on the scorecard, they need to be something, obviously, that we can measure. They need to be something that the provider is capable of managing, and then it needs to be something that's meaningful to the patient as well. So we divided these up into 4 bundles of care, one general care, one related, and then the other 3 are related to our specialty care programs, so STEMI, stroke, and trauma. The source for these KPIs are several well-established kind of standard of care things such as the California Core Measures, NEMS QA, Mission Lifeline, and TQIP. So additionally, we're providing the opportunity to offset any response time liquidated damages by providing exceptional clinical care through the use of this clinical scorecard. And then we are requiring compliance with the clinical standards to earn extensions to the contract as well. Next slide. So we just wanted to highlight, we talked about collaboration and cooperation early on as one of our goals. So we want to highlight some of the efforts that we've undergone to ensure opportunities for input throughout the development of the RFP scope of work and then the initial public comment period. So we're providing opportunities to submit comments both verbally and in writing. We're working on scheduling a couple of additional in-person public meetings that we will be releasing dates and times for shortly. We've issued a press release. We've placed ads in local newspapers. We've made many posts on social media, added information in a banner on the EMS agency website, and sent out push notifications through our app. We've distributed all of this information to all of those who are on our various mailing lists, not only for these committees, but our QI committees and those who have expressed previous interest in prior RFPs. As I said, hosting the public meetings for both the community and our stakeholders. And then we're holding this joint meeting with EMCC, CCC, and OPS. Next slide, please. So as far as next steps in the RFP process, we have the public comment period that's scheduled to end on November 17th. Once we've been able to collect and review both the comments received in our public meetings and the written comments, we will go to work on revising the RFP scope of work draft as needed and based on the feedback that we receive. Once our work is done, we get to turn that over to County Council and County Contracts and Purchasing for their review and then make any additional edits that are needed from there. And then finally, we'll send it to the EMS authority for their review and approval. Ideally, they love it and they approve it right off the bat, but we may have a bit of a back and forth to work out some of the finer points of the RFP. Next slide. So we anticipate anywhere from 30 to 60 days for EMSA to issue their approval based on just kind of past experience. So we would like to get the draft to them by the end of the year, go through that kind of back and forth with EMSA, and then be able to issue that for March 2024. As soon as we get that back from EMSA, we should be able to turn that around very quickly and get it out to the public. So the next kind of steps are to be determined based on when we hear back from EMSA and when we are able to issue the RFP. So those will include a mandatory pre-proposers conference, a submission of written questions, and then our response to the written questions. We'd like to establish a deadline for proposers to submit their proposals May 2024. We would spend June 2024 in the review process. Then we would enter into a notification negotiation agreement period. And we would be working towards a Board of Supervisors decision July 2024. And then one of the unique things about this RFP as well is that it provides for a year-long transition period in which the winner of the RFP process would be actually under contract with the EMS agency and responsible for certain metrics throughout that year transition period. So that would go from the Board of Supervisors decision until June 30th, 2025, with the service start date of July 1st, 2025.
And of course, the timeline is rough. The biggest unknown is when we get that approval from the state. And we try to build some flexibility there and subject to change based on what happens, particularly with obtaining the approval from the state authority. I would like to close the presentation just to reiterate that the EMS agency is very committed. We take our responsibility as a lead agency for this county to continuously work on improving the system and in using those improvements and other ideas, other information that we may be able to obtain to develop the next RFP. We are bringing this scope of work for your discussion, and we really would like your input. And we know that very candid conversations happen in this setting, so we really appreciate it.
Teresa, before we open it up to feedback and discussion, would you like to address how your organization plans on capturing and has captured the feedback, and how you incorporate it, and if there are questions, how you'll be answering those questions? Today and throughout this process, in particular with the feedback that's going to be obtained today, and I guess what you've obtained in the past.
The feedback that we've have obtained in the past is reflected in the scope of work. In the best water analysis, we took a look at that as we were drafting in making changes to the scope of work. We try to keep in mind the limitations that we have as we, to borrow Dr. Burley's words, trying to add more tools in the toolbox, what the limitations could be. We are unable to draft a scope of work or an RFP that anticipates every change or every aspect or every model that there could be in the future. So today we'll hear the discussion, we'll take the questions, whatever we can answer, we will answer. If it's something that we can answer, we will take it back and consult with whoever we need to consult with at the time. And then we'll compile all of the information. And as we did with the SWOT analysis, it could be made a public document posted on our website as well and being brought to the communities as well.
And so just clarification for everybody that's involved in the meeting, what you're saying is that just due to some of the restrictions, you may not be able to respond or answer certain questions today, but you will be compiling information and discussing it with your staff and then coming back and putting together like a written answer to some of those questions that will be made available to everybody. Is that correct?
That is correct. We may need to consult not a conversation with staff. We may need the conversation with contracts purchasing, with county council, with the EMS authority. Maybe requesting some of that technical assistance that we mentioned before, as we work through the changes to be made in the RFP.
Oh, okay, and then just one last thing, this is just from past experience here. I didn't know if you or anyone in your staff would like to address what you can respond to, what you can't respond to, and why you can't respond to it, so that people aren't walking away from this saying, oh, they won't respond to it.
That's a hard question. Because sometimes we won't know until the question is asked whether or not we can answer that question. And yeah, so we'll do our best to answer the questions that we can answer. And if there's something that we really can't, we will follow up in when we compile all of that feedback, including questions asked through this public meetings. We're going to compile all of that into a single document with the agency's responses. So at some point you will get an answer. If you don't get it today, you will get it. There will be an answer, and it might come in the form of the written document when we put that together.
Okay. I guess with that, we will open it up to, I guess, like just feedback from everybody, all committees, and Mike, go ahead.
Yeah, so, I don't think that we have a lot of questions. I think that we're going to, we're still doing an analysis on our own. We plan to submit all of our questions by the 17th dictated, but I am going to make a request and sort of a plea publicly. I think that the timeline was really well intended, but I would like to ask that the award not be a year out. I think that would create an extreme amount of instability within the system. For lack of a better term, I think it would be a year-long funeral if we were not the successful bidder. I think that you would have, probably some, an exodus of leadership, and probably, just from the field side, just, trying to maintain kind of compliance to, our own policies and everything else. So I did check around to a lot of my peers, just asking what that standard would be. I've been through 12 RFPs, and typically it's about 6 months is typically the award time. And I recognize that, there's a lot of complexities with having to purchase vehicles and, search for, properties, things like that. But I think that would provide ample time. I do feel that a year out would put, if in the unfortunate event that we were not the successful bidder, it would put us into just an incredible amount of, instability, and I think it'd be problematic. I think that, our interest, of course, would be to maintain, quality care through the very end of the contract. And so that's what I would ask. Then the other question, if I could just ask too, is that we would like to try to get some definition on the community equity in terms of how that would be measured. Is it by zone, by the color zones? Is it by zip code? What actually defines compliance to community equity? Not being very eloquent in my questions, but that would be a big question for us.
Well, I have a little bit of feedback. One, I know in the past, and this has been an ongoing issue, or I should say, gripe from the South County area, is that we would like to have some of the data for the priority calls extracted and specifically see. And I know that your staff did spend a lot of time and did do that earlier this year, but we'd like to see that on a regular basis. And our understanding is that you've not been able to do that because your software isn't designed to do that, or you don't have the tools to do that. That being said, I see this RFP as a potential opportunity to maybe incorporate some of the changes that would enable you to do that. And I think that would be, it would be very useful for all the different agencies, not just the South County agencies, but other agencies to see, you know, what is and what isn't going on in their respective areas. The other thing, and I know that it's not specifically addressed in there, but just going forward and with any modifications to the RFP, I'd like to request that that there is the ability for partnerships with the contractor and public-private contracting opportunity or partnership opportunities. With that, I don't have anything else.
Thank you, Chief.
Teresa, a major issue from a citizen standpoint in the past has been the change of coverage in specific areas. I think that that's probably one of the most emotional, in addition to it not being an operational issue, it's one of the most emotional issues that we've encountered in the past in the previous RFPs. So I would always ask that it be clearly articulated in the RFP. So you don't have to dig through it and look for changes that affect individual areas or sub areas.
I'd like to touch on the workforce protection that was discussed in the RFP, and frankly, it's disappointing. It's very lacking. The language that was included in the RFP states that you will strongly encourage and make the contract winner will make every effort to hire the incumbent workforce and keep a similar pay scale. But there have been many surrounding RFPs that have required that. I'm wondering why that wasn't required in one of our counties.
We'll have to take a look at the language again, just to make sure. But we hear your concern.
Was it Medtrans did that, right? The whole big, anyway.
I don't remember.
Yes, it was Medtrans, yes. Let's see what that.
I just want to highlight the CCT. I know we've talked about it, but really reiterating the need for those resources, although the volume is low, when they happen, it's somebody's life, right? And things have to happen quickly. I think if, because it's a low volume thing and resources are lower, I think there should be an option to either utilize another transport company, something that stipulates a little bit of flexibility with getting these critical patients to tertiary centers. Time is of the essence.
Some sort of backup process.
Right, like a backup, some sort of backup process that allows the medical facilities to utilize if those resources are not available.
Because our current backup process of switching to air transport, you know, I think is increased expense, you know, personnel safety issues, patient safety. I mean, it's very problematic. You know, we're kind of overdue for a crash. We should look at that. This is from us at SVMH. You know, we also have concerns about, you know, delays for facility transfer for both ALS and BLS. And we would like to request that, you know, a better tracking mechanism for all the things we were just talking about get put into place, and that if you presented at the CCC meetings going forward, so we can keep an eye on that, because it's a real problem for a hospital. I mean, we only have 15 beds, you know, so we have 3 or 4 holds, and all of a sudden we lost, you know, 25% of our bed capacity, right? You know, and then we're here, you know, offload times, all this kind of thing. Right? So it puts a lot of pressure on you know, on us, and it leads to huge patient care delays and stuff like that. You know, the real fear for the CCT stuff is that we'll have one of these events happen when the weather sucks and we can't get someone out dying. We're kind of overdue for that too, because it's happening with increased frequency, you know, and sooner or later it's horrible. So we have a lot of concerns about that. And so that's it. So for my EMCC part as a physician representative, I talk to every emergency department director, via email, and everyone has similar concerns about facility transports.
I may as well echo in since we're talking about it. I have a list. I'll send it in the public comment form, but I'll go over some of them here. I think transfers, CCT, behavioral health, they're all low volume, predictable, but very high risk, right? This is your sickest subset of patients. If you've sent somebody to a facility here that cannot be taken care of, this is a higher level of care transfer. And I think if you talk equity within your system and how you approach things, the way you place behavioral health as kind of being non-medical is an inherent inequity. I mean, some of your terminology, I think, really needs to be looked at. Because this patient population, both chemical dependency and behavioral health, has a higher mortality rate than most of your chest pain, STEMI, cardiac patients in a 12-month period. This is your highest risk subset. And while you're not putting a defibrillator on them and you're not giving them nitroglycerin, the interventions, if you're calling your ambulance inhumane, and that's in your definition on priority 7, I think it is, which also needs to be fixed because it's incorrect. It doesn't correlate with the rest of your priorities, and I'll get you that info. But if you're categorizing things as potentially inhumane, I think what you're trying to say is you want to find a better way. I don't think you want to say, the ambulance is an inhumane thing, or, it's leading to less expense. I mean, it's marginalizing a marginalized population in my view. And I'm kind of passionate about this because I have these people living in my department. And it's because we have system failure. And it's because you haven't done 200 transports that would benefit from a psych facility. And it's because there are no psych facilities in the state to take these patients, right? So they're living in my hospital, and that's not right. So when we get a bed and I hear that we can't transport for 24 hours or 48 hours and I lose that bed, it's even more critical. And the fact that the system is aware of this and we're kind of giving overload parameters that are destined to fail. I mean, you always have something pending. So to have 2, you're going to have the failure rate at a percentage that's so dang high that you never have to meet a metric. And I think we need to do better because this is the highest risk patient population that you have. These are people that are too sick to be taken care of at a facility that has, for us, STEMI, stroke, psych, peds, ICU. I mean, neuro, everything is there except trauma and a locked psych facility. And there's places that the EMS agency could do so much better. I mean, we talked about it. I came to you guys and I said, look, I'm giving you a patient subset that is very high risk, that is critically risky when you go to transport them again. And if you could get them to the right place the first time and avoid your secondary transfer, that would be huge. But we didn't work that out in our system. This is specifically referring to violent behavioral health patients that can't be hospitalized in my facility that are preferentially triaged there from places like in Marina, where we're equidistant to a locked facility. There are things that we can do in the system to make those numbers less, not artificially by having patients on long-acting antipsychotics in my department, but by optimizing the system to provide better options. And I hope that the RFP can reflect this. And I hope that the language gets changed where the RFP, rather than saying, these are non-medical patients, these are, behavioral health only, it's like, that's very medical. Psychiatric,
Yeah.
The psychiatrists are medical doctors. They deal with the most complex organ that we have, the brain. These are huge imbalances, and we need to treat these patients medically and recognize that our medics and our EMTs can be given the skill set to appropriately intervene. The safe transport of this patient subset that's in crisis is critical. And whether we do that, how we do that, we just need to make sure that it's done right and that we don't marginalize them. You definitely have definition issues. The interfacility transfer, I'm transferring what you call a medical patient, non-behavioral health. That means that these are the sickest people in the entire county. They're going to a regional center. These people are going to die if they stay in my facility. And right now, the way you have things worded, your kind of priority 3, kind of code 3 response looks to me, and I personally have been in the system forever and thought that it was limited to stroke, STEMI, and trauma. I didn't know that I could say, hey, I want a code 3 response right now for this. I can't get a CCT rig when I call for it, by the way, which is a problem because most of these patients are on multiple drips, which then we'd go to Aero Medical Resources, which maybe that's a partnership that we should make. Maybe our aeromedical resources should also have ground options so that we can get them out on the ground when we can't fly. Because this county, by me especially, is notorious for being fogged in, right? Certain times of the year. And these people will die in my facility. The other day, I could have easily put somebody in a ground ambulance that needed to be dialyzed ASAP, had no dialysis capacity at my facility because of an issue. Normally I do. Couldn't believe it, but I had to get an air ambulance to get the patient out timely. These are predictable, low volume, incredibly high risk system issues. This is your sickest patient population. I'll send the list, but I think we need to do better in our RFP and better in our language. And I also see other language that hopefully can change. You know, if you want to talk about inequity and marginalized people, you specifically call out bariatrics as having a longer response time. Kind of, you know, you can take up to this and have a way to get there. I mean, you're now equity in the system. We don't marginalize, right? All patients are treated the same, but we've separated them out. So
I was gonna actually mention that too.
I think as a system, if we're really looking for equity, we can do a heck of a lot better. Sorry.
And it also infiltrates into the inpatient side of the hospitals, right? Like, SVH and CHOMP, they're cardiac centers. And this is also another subset that, when they need tertiary cardiac care or stroke care and they're on the inpatient side, that's a whole nother sort of ballgame. And then the bariatric side I wanted to mention as well, because we don't have that service in the county. And we had a bariatric transfer to a tertiary center and it was delayed several hours because we did not have a rig for this patient. So that goes with I think that should be addressed.
And I mean, we do have, there's another group where if we appropriately get them to the right place, some place that has a scanner in that capacity, and maybe this is a dispatch question, can you give me a height and weight on this patient or approximate, right? Like, I don't know, but they're super huge. I don't know. It seems like we can do better with some of this. I'll send you a list of what I think, just my perspective.
Yeah, I mean, I kind of feel like where you get the leftovers from the 911 system, right? Right, when we're, and if it's gonna be an exclusive ambulance contract, there has to be some kind of guarantee that we get appropriate services at the hospitals.
I have two questions on the chat. One question was, could there be clarity?
Can you speak a little louder because I can't hear you?
One question is, could there be clarity on the definition of scheduled versus unscheduled interfacility transfer?
Okay, yeah, actually, can I jump in on that real quick? So the way that the tracking is being done on this drives me nuts, okay? Because, when AMR dispatch talks to our charge nurse and they say, okay, we'll have an ambulance there at, 5 p.m. in 12 hours or whatever. And when they say, okay, it gets categorized as a scheduled transfer for like CCT and stuff like that, right? Which is obviously not the way it should be tracked. So we need to find a different tracking mechanism. Those aren't scheduled transfers, they're ASAP transfers that if that's the first ambulance we can get, yeah, we'll take it, but that doesn't make it scheduled.
Right, but what he's saying is it kind of then ends up in a different section on your list where it really is a system failure, right? When I'm calling for a CCT, that's a critical care patient that needs to be somewhere else. I really don't want to wait 5 hours. As a matter of fact, it's a one-on-one nurse that's now pulled from the operations and the rest of my emergency department. And it needs to be at a facility that can care for them. So these should be failures of the system. And honestly, you have such easy, they're going to be able to not meet any metrics because of your overload definitions, right? 2 cases is an overload system. They plan stuff 24 hours in advance for behavioral health on a daily basis. So any one transfer is now going to be overload. This is predictable.
But it's overload in relation to what's going on in the system. If the system spikes with more 911 calls that are high acuity calls, that's when the overload kicks in. And Kimberly, you know this area better than I do, so correct me if I'm wrong.
That is part of it because there's 3 parts to the overload.
Can you get up?
Sure.
Thank you.
Okay, so what Dr. Kolinsky is saying is not incorrect. She's saying that if there's 2 transfers pending, that's considered overload. If there's 7 or less ambulances in the system, not including the big SIR unit, that's also considered overload. So there's separate pieces to it. so.
So what I'm saying is that by defining it in this way, we've got a no and high risk entity. These are your highest risk patients in the county, honestly. So if I'm sending out a patient from my facility that I can't care for, they're pretty dang sick, right? They're guaranteed to be admitted if they're going critical care, you know, and we're looking, these are sick people. And when we contact for response, and I just found out from Ben, thank you, that I could probably ask for a code 3 response and get by with it. The problem is that then I don't have my CCT, right? There's no, your CCT availability is so limited that gets scheduled. So we'll hear, well, I'll get a CCT through in 5 hours or 6 hours or things like that. And then those don't fall in the metrics frequently because now you've got 2 cases pending and then anything else is overload. And so I just think we need to tighten what we're requiring and what we're asking because this isn't going away.
Yeah,
The
it's gonna get
regional
worse.
components of healthcare and that hub and spoke component is gonna get bigger and bigger. We can do better within this county to try to get people to the right place the first time. We do really well with, you know, stroke, STEMI, trauma, we have parameters, but we know where our other high-risk transports are. And we can really work towards trying to get some of those populations down.
Can I ask a question? So what percentage of the time is the system on overload?
It's really hard to track. I mean,
They don't
it
track
can fluctuate so
Okay.
much. I mean,
You
I
guys
mean,
are
I'm gonna
not
be
full
honest,
tracking,
it's
I
almost
just like-
impossible to track how often, but we
For
do
transfer.
have the transfer delays that we do track.
I mean,
So we could,
but we should be tracking
Exactly.
system overload status, right? I mean, if this is a metric that we're gonna use to define, you know, whether or not we get an ambulance, all these kind of things. I mean, if we're always on overload status, then there's a system problem, right? So this is a metric that definitely needs to be tracked, right? Along with all the delays in CCT. I mean, we're not even tracking these metrics, right?
we are tracking delays.
You know, well, I don't think so, because when I just like the ambulance thing, right? When AMR calls back and says, we'll get you an ambulance in 12 hours, and we say yes, then it goes down as a scheduled transfer.
And we
Right.
track those. Anytime they give an ATA, like.
But you're not just transferring the delay, because when I look at the data, it doesn't make any sense, because it looks like you guys have a, 45-minute response time to our facility. And I've only seen that happen like, like a couple times this year, right? So the way that's being tracked is a little bit disingenuous, because it's not a reflection of when we call for a critical care ambulance in an emergency, and as soon as when we can get is 6 hours, yeah, okay, we'll take it. But that's not a scheduled transfer, right? That's as soon as we can get an ambulance, right? So the way that's tracked doesn't make any sense from a hospital standpoint, right? From AMR, dispatch standpoint might make sense, but from a hospital standpoint, we want the ambulance, we call it for it, right? Right? We're called, these are CCT transfer from emergency departments. These are what Kalinsky was just talking about how, sick they are.
No, I mean, I
Sick
totally
population,
understand that. I mean, we all recognize that CCT, like if that CCT nurse is on a transfer,
Right.
the next one that comes in is going to be delayed. I mean,
Right,
it's just-
right. No, I get it. But I get frustrated when I have an aortic dissection case that needs to go to Stanford and I can't get them out. And then it's, a scheduled transfer. It's not a scheduled transfer because, the mortality goes up 10% every hour. It's not treated, right?
Right, and
But
there is the option, and like Dr. Kalinsky said, Ben just told her, if you have a patient that is going to deteriorate in the ER, you request a code 3 transfer.
The problem is that if you don't have the appropriate level of care, meaning the CCT resources, that doesn't help us.
I understand.
So this is where I'm asking for the system to become kind of more flexible, more robust, and try to address this known need, because we know that it's a need and we know that we have failures.
it
So-
just needs to be tracked, right? That's my big thing. We need a tracking mechanism for all these things and we should be looking at it on a monthly basis because we don't know how big a problem we have because we're not tracking it.
Or if we are, the rest of us don't know and
Right.
we don't recognize kind of the full system effects.
I could just kind of summarize that and tie in one of the things that I brought up earlier. I think what we're hearing is that without the data that's reliable, it's very hard to say what is and what isn't, and then to make system performance adjustments based off of that. And so I think maybe the takeaway is, putting language or considering the need in the RFP for the provider to be able to work with the EMSA in a way to provide very specific data to address these different things so that we know what is and what isn't. And it takes it away from what may be thought of as our perception. You know, like my perception is at times it seems like we're waiting a long time for an ambulance, but when you look at the data, we may find that that's not the case. But having the ability to do that, I think is important, and hopefully you're seeing that.
The next question was, does draft RFP providing exclusivity to the winning bidder preclude alternate ambulance companies from becoming licensed in county to provide ambulance transport that the winning bidder is not willing to contract for?
Can you repeat the question?
Does draft RFP providing exclusivity to the winning bidder preclude alternate ambulance companies from becoming licensed in county to provide ambulance transport that the winning bidder is not willing to contract for?
So the RFP does create an exclusive operating area, awarding the contract to a single provider for the services included in that scope of work. In the current draft of the scope of work, there are some sections where we are allowing the proposers to tell us how services will be provided. We are saying that the county will allow that the services can include like the backup CCT, for example, or a subcontracting in some cases. So the areas where that can happen would be prescribed in the scope of work. But in essence, we are creating the exclusive operating area. The contract is awarded to a single provider.
Right, that it doesn't, the RFP does not prevent subcontracting, but that would be
in the areas specified in the scope of work.
Do you, how many more questions do you have, or comments
One
do you
more
have?
question and then one statement.
Okay, and then just in general, we see a lot of people getting up. I don't know if there's gonna be more discussion, but if there is, we could take a 10-minute break right now. Or if there isn't, if we're coming to the end of our discussion, we probably just move through it. So is there?
To the chair, I'd like to make some comments, and then I'll be done with mine. I'm gonna keep mine fairly brief this morning because we will be submitting comments on behalf of the fire district before the deadline. For those of you who don't know me, my name is David Sargenti. I'm the fire chief of the Monterey County Regional Fire District. We service 400 square miles of the county in the northern portion of the county. My comments are going to be focused just on comments, not asking any questions at this point in time. I would like to acknowledge that the EMS agency did an excellent job early on with the SWOT analysis. That was something we haven't had the opportunity to do in the past. And my agency did submit concerns and some comments about looking at modernizing our system, looking at ways we can look at alternative destinations, how we can have collaborations and cooperations to enhance the services. Unfortunately, those weren't incorporated in the RFP. I see this as a retread from the previous two attempts, failed attempts, if you will. I see no improvements to the service areas, as Mr. Robbins indicated. He'd like those identified. Well, it's pretty easy here because there have been no improvements in response times in any of the areas. And the funny thing is, when you look at the map, it still says 2013 on it. So there has not been any improvements. That's a concern for us. We service a very rural area, but it is populated within or near the towns of Salinas and the Monterey Peninsula, yet that's where our ambulances are coming from. So there's no enhancements there, and that's disappointing for me as the fire chief, as we look for ways we can enhance those services and provide a better level of service for our constituents. Here, 20 years later, we're in the same thing we were before. An example of that is we have an 8-minute zone in the city of Salinas, and right next to it, we have an as soon as possible. How can that be? How can there not be a degradation between 8 minutes to 12 to 16 to then as soon as possible? there's areas of that map that really need to be improved. And really, it is 2023. We should have a GIS map that we can scroll in, scroll out, know exactly where those boundaries are, so we can make adjustments to our protocols and to our deployment standards as well. So really what I'm looking for is we really do need to look at the system as a whole. We need to look at modernizing that, look at ways and opportunities we can create to enhance those levels of service to the end provider. And as you guys mentioned in the PowerPoint, how we enhance that experience for the person that really needs it, that end user, that customer. And what are we doing as an organization and as the leaders of VMS in our county to make those improvements? So thank you for the time, and I appreciate the opportunity to comment.
Hey. Thanks, Chief, for kind of kicking that off. I have some general comments as well. I will be submitting quite a few questions to this draft, but I echo a lot of what Dave said, and just what I want to say is, again, having lived through many of these RFPs in this county, many years, is exactly that, is that we need to enhance the system. And to me, an RFP document that allows the maximum amount of flexibility to be creative, to allow for this collaboration to take place, is one that has any chance of being successful. There was a comment kind of made earlier that the EMS agency is an enforcement agency, and that really kind of struck a nerve with me in that we really need to think bigger than that. Looking at this contract moving forward and how the fire service integrates into it, is that we're the ones left holding the bag when this is all said and done. When these RFPs fail, we're ultimately responsible to our constituents, whether you're a special district or you're a municipality providing services under a charter. We're the ones that are going to be here long after a private provider or a public provider or an ambulance contract is through. So looking at the fire service, and I use the state mutual aid system as kind of an example, in that we all have our individual strengths. And I mean the fire service, private ambulance service, local government, we all have resources, but we're all challenged over these last several years with those resources really becoming taxed at all levels. Staffing is number one. I look at the 911 center and their mandatory overtime and the burdens that that's putting on the system. I know AMR and private ambulance is in no different situation in being able to attract and maintain staffing for all of these things. And when I read through the scope, there is still a lot of burden put on performance items where flexibility in an RFP would allow pooling of resources, specialized resources, to make the system better, to make the system more resilient. When we look forward at the provision of emergency services, sometimes we confuse the words efficiency with fragility, and making an efficient system often makes it fragile. We really need to be looking at being resilient. So making an RFP that's flexible, both for a contractor and for local government to participate, is one I think that is more innovative. And I would agree with Dave that I'm struggling to find the innovation in this current document. Thanks.
If I'd like to add one thing here, summarizing some parts came up in other presentations. But, we have a potentially here a 7-year or a 12-year contract once it's full length. I'd like to ensure that the RFP addresses growth areas that could be expanding or changing. Our situation is not static in this county. We've had growth in the past, and sometimes I've been very concerned in the manner in which it was addressed from the overall program. Individual agencies like fire agencies, law agencies are much more, how should I say, prepared to adapt, accept, and integrate those areas. I want to make sure that the RFP process identifies that for the ambulance care, and that that's integrated in the system as well.
If I may. Sorry, I didn't introduce myself earlier. I'm Andrew Fife. I'm the president of IFF Local 4513. So pretty much all of the workforce for Bonner County paramedics EMTs and dispatchers. We have over 150 with Monterey County right now. With the current language that's in the draft with the incumbent workforce, it's pretty lenient on whoever comes in and bids. Pretty much the only protection we have is if AMR wins, then we can keep our jobs. If a new provider comes in, they are only encouraged or make reasonable effort to hire us. That's kind of saddening. Also in that language, it only says if AMR wins, then we get to keep our wages, pays, and benefits. But another provider comes in, there's no language for that. So we would have to go back to square one and fight all over again for what we've been fighting for some of us for 30 years. So with that, I hope that we can work with the EMS agency. I think the committees are 150 strong. Work day in, day out, do all these 911s, these transfers. We know the struggles of the system. We work it, we live it. So we hope we can work with that since it is a draft. Hope we can create other language in that workforce language. One other question I want to ask, in the RFP, it is signified that a CCTRN or a CCTP can be staffed. What I would like to ask is, what is the county doing on the back end to make policies, protocols on that CCTP process? We don't have it currently. So if that's enacted, what can paramedics do on a CCTP?
Yeah, I mean, at least you don't flex unit or something like that too.
So in the scope of work that we have, the language that is in the scope of work does not dictate the CCT program. As you saw in the presentation, we were looking for ways in which we can have some of that flexibility and take advantage of the provider's expertise. Currently in our system, we are the contract requires the provider to maintain a nurse 24/7 for CCT. And we know what the challenges of that is, that, that nurse can be called to be on one call, another one comes in, likely the second one is gonna be delayed. So what we've done is allowed for the proposers to tell us, how will you provide CCT? The responsibility to provide CCT is still there, but how do you propose to provide CCT? And we are saying you can do it through a CCT program, which other jurisdictions have, or a CCT nurse, or something else. We are also saying that CCT backup is allowed, to speak to what you were saying, that, being able to, if the nurse is not available, or whoever at that point, depending on what that program becomes later, then backup CCT services would be allowed, that we are open to that. So we're trying to find the ways within the scope of work, following the limitations that we may have based on the requirements that we have to meet from the different entities that we are working with, county council, contracts purchasing, and particularly the state, as to what we can do. These contracts are very strict, not just the process, the way that it's overseen, but how much flexibility is allowed is not up to us. We would like to put ambulances everywhere. It's not feasible. There are things that we're trying to do that the state may say, not quite the way you want it, or you can't do it that way, period. So we're trying to balance all of that. We're trying to meet the needs. We've heard from the hospitals on CCT, on behavioral health, on wanting more tools in the toolbox. I continue to borrow that from this work. But there are limitations that we have. So please do understand that we do have our intention is to bring the best set of services possible, but then we have to talk about the rate. What is the rate that the residents, the patients will be able to pay for the services? Let's just say, well, we need 2 CCT nurses, instead of 1. What does that mean to the rate? We need more ambulances in the system. What does that mean to the rate? We have to look at how the scope of services will affect what residents and visitors of this county will would have to pay for when they call that 911. And we don't want to get to a point where people will not want to call 911 because of the price of that ambulance ride to the hospital. I hope I answered your question.
I guess if I could add into, the state EMS authority regulates the process for critical care paramedics. So one of those things that would need to take place during the transition period, because we don't currently have those in the county, is the development of that program and working on EMS authority approval and building out that whole program. So there would be a lot of effort on our part to get that in place if the successful bidder does choose to go with the CCC paramedics.
Starting a couple comments and a couple questions, rather, and see if you can answer them. So with the 5.5.9, the ambulance staffing requirements with BLS ambulances, I saw in the PowerPoint that you referenced them only being used for interfacility transfers, or they're not going to be used to try and augment the 911 system. That's a question. Okay. The next item that I have is 5.11.2 standby services for government agencies that would allow the contractor to bill in certain situations where we request them to do standbys. So Monterey County protocol for fire agencies is whenever there's a structure fire and ambulance gets dispatched, our AMR partner, our ambulance partners always provide that services. I'm just curious if that's a new thing that it's saying after 2 hours that they could bill, doesn't mean they're going to. But I think what this bigger picture is, and it sort of addresses what I brought up in the MAC meeting right after all of the floods with the Mohawk, is if the DEM gets activated and the Mohawk unit gets activated, my question was, how is the private provider now going to be reimbursed for the time when they're told to stand up ambulances? So reading this, it says they can, and they can bill that agency. I guess what I would want is clarification. Are they going to be billing the EMS agency, or are they going to be billing the Monterey County DEM or state OES, or just a mechanism for them to be able to seek reimbursement in those situations? Next one. This is sort of a soapbox thing, but 5.13.4 billing collection services. I think that the RFP could be a little bit more inclusive and representative of the citizens that live in the community. So us that do have private insurance, when we use the ambulance service, the private provider, we have no choice. We call 911, the private provider shows up. Then you get the bill in the mail. And you're told by your insurance company, we don't have an agreement with that provider. We're only going to pay this base rate. Guess who has to pay the rest? The citizen. So can we have some language in there that encourages the new contract provider to look at the, let's say, the top 5 insurances that are offered in the county? I'm sure that data is available with all the county employees, the city government employees, all your produce agencies, your healthcare systems. We're all in pretty major insurance companies of having some stronger language to take those 2 entities to the table to negotiate some better terms so that the end user isn't the one that's on the hook for the other $3,000 that your insurance doesn't pay. Additionally, the ambulance providers, even our ambulance providers, we accept the Medi-Cal and Medicare reimbursement and we wash everything else away. So you're sort of penalized for having a better level of insurance. Okay, the next thing is 5.13.13.1, administrative oversight fee. I'm not quite sure if this is new, but I guess I'm seeking the rationale or the justification on why the ambulance provider needs to pay the EMS agency $200,000 a year. To me, this sounds like a pay to play. You want the contract, you got to pay it. You got to pay to have that contract. Additionally, our concern as public agencies is where does that stop? So if you're going to start billing the private provider for what you're calling regulation, oversight, administrative, quality improvement, EMS infrastructure as identified, what stops them from that going to the ALS fire, BLS fire, the other transport agencies within the county? And I think Chief Sargenti already covered it, yeah, with the map. I think we could have more of a detailed map that we can expand on so that we can actually see where the actual response times are. I'd also like to echo, I know Spencer said it, Fife, you said it back there too. The incumbent workforce, I think that's important. There needs to be stronger language in there to protect those employees for all of the things that they fought years and years for. And to be honest, even what they have isn't enough. And they do that work every day, day in and day out, supported by their partners in public safety, but they are the root of the system. If we don't have the employees, the system fails. Thanks.
Any comments or questions?
We have comments online. There's a few more, so. Okay, you state the EMS agency will work with contract to ensure receiving hospital maintains ambulance patient offload times within the standards identified in EMS system policies, protocols and procedures. What policy is this outlined in?
Something about patient offload times.
Teresa. So the EMS, pardon me, you state that the EMS agency will work with the contractor to ensure receiving hospital maintain ambulance patient offload times within the standards identified in the EMS systems policies, protocols, and procedures. What policy is this outlined in?
We do monitor the patient offload times. I hate to call you again, Kimberly. It is something that she does on a weekly basis. The patient offload times, they stay pretty much under the 20 minutes. We do have, every now and then, we have some outliers from some, and it could be 1 or 2 hospitals where the patient offload times are extended. So we do monitor them. We will continue to monitor them. There is an effort at the state level to set up some standards. If the state does implement those, then we will have to follow the state's requirements for patient offload times. We worked with the providers some time ago because we were getting, and I believe it might have been through the unusual occurrence filings that we were getting some unusual patient offload times. So we work with Mike and his team, and had some conversations with the hospital, which was one of the reasons why we monitor that on a weekly basis. Kimberly gets a report out every Monday. She reviews it, she sends it out to the hospitals. We look at whatever in the system is, but our offload times are, for the most part, under 20.
Yes, the majority of patient offload times, I mean, I don't have the numbers in front of me, but I'd say at least 90% of all the hospitals, their patient offload times are under 20 minutes. So I communicate with each of the base hospital coordinators at each hospital to find out if there were any outliers, what was going on in the ER at the time, or, I mean, sometimes it's just they were busy or there's a reason why there was an extension for a offload time, but it doesn't happen very often.
Yeah. But I think the question was reflecting what is the policy that your RFP is referring to, or the standards, and I think that's what they're looking to tighten up, because I don't really think we monitor this, right, but we don't really have a policy per se, right, that we're referring to.
I cannot recall.
I
any of
don't
our
think we
policies
do,
off
and
the
so
top
I
of my
think
head.
either the language in the RFP would need to reflect that it'll be monitored, and if we see, outliers beyond X, we will, intervene with the hospitals to determine how we can mitigate. The language needed to be fixed and not refer to a policy that doesn't exist in the system.
So Kimberly, in that question, did they cite where in the contract that was located?
No, but I can ask them to.
And then we have a few comments and then 2 questions.
Would you mind standing up and just talking a little loud? I can't hear you.
So we have 2 comments and then 2 questions. So the next comment is, you really need to have an understanding how often we have more than 2 transports required in huge county at a time. This is a patient care issue. The next comment is, my name is Alexandra Pimentel. I'm a paramedic in the county. I have a comment for the RFP. I have worked in Monterey County since 2016 and in EMS since 2012. I also live in Monterey County. I have grown up here most of my life. I like my fellow coworkers and union members to see some wording added to the RFP for protection of our jobs, pay, and benefits. A lot of my fellow coworkers have been working in Monterey County for numerous years as well, and many live within the county. I would feel more comfortable having these individuals treat my family. It would be unfortunate for a new company to come in and either hire an entirely new workforce that do not understand this county, the inner workings, have the relationships with allied agencies, etc., and or have the seasoned individuals who have been here a long time start at square one regarding pay and benefits as we, a union, have fought to earn. And then the next question is, has the impact of a CCT program on air medical been considered?
Can you repeat the question?
Has the impact of a CCT program on air medical been considered?
So you asked for the section for ambulance offload times. It's 5.4.14.2, good cause exemptions, number 3. It refers to standards identified in EMS system policies, protocols, and procedures.
I still didn't get the question.
Has the impact of a CCT program on air medical been considered?
Air medical.
And then we have Michael Van Elgort on, he has his hand up, so he's gonna ask a question.
Hi, good morning. Hopefully you can hear me. I'm Michael Van Elgort, currently the program director for the South Bay MPC paramedic program, situated in Monterey County and under the accreditation rules of Monterey County. And I just wanted to offer that, including some language as it relates to paramedic training and a CEU, and in partnership with public and private agencies and your accredited program is something that may have some value as you craft your RFP. And then I will say we're en route to completing our accreditation. We're in our LOR process and should be fully accredited by middle of the year. And is there a plan for embedding or saving roster spots for allowing EMTs to train in county to become paramedics for the incoming agency? And is there any partnerships with public providers or public safety providers to do the same? I just wanted to give that off as an offer, and that's my comment. Thank you.
Any others?
I had a question about the subcontracting, sort of the process, who will mind that process once the hospital, once the subcontract, I'll speak up. Regarding subcontracting with transfers. I'm wondering who will be responsible for minding that, who will be calling in the subcontracted ambulance, and if there's any fee structure associated to the new provider if a subcontract.
The provider's responsibility for the subcontract.
So for minding who's coming in to take that transfer and the payment as well?
Well, the calls are dispatched by the way that it works now, right? But now with the subcontract, if there's a need to call an alternate provider, let's just say the current scope of work says that the contract allows for subcontracting, right? You could. It doesn't mean you are required to do so. If a provider says, no, I don't want a contract, I can handle all of them, they meet the needs of the hospital. Let's just say that is, then you don't need to, then a provider would not need to subcontract. But understanding, again, in our effort to add more tools in the toolbox, we're saying there's a demand We understand that there may be multiple transfer schedule, multiple transfer schedule around the same time, and to give an opportunity for that flexibility, allowing that subcontract. But right now, the way that it's written, it does allow the provider to subcontract in the same way that you do mutual aid.
I may make a suggestion though, if you're confused by that, I would imagine that a lot of other people were. So maybe the RFP should have more robust language that reflects that the contractor is responsible for the subcontractor's performance and meeting whatever metrics are defined and, whatever other parameters, the dispatch, the arrival, all of that, so that it's clear to the people that are looking at the contract what that would entail. Because maybe they say, oh, I subcontract, it's no longer my responsibility, right?
It's, if I may, it's fairly common that if an entity subcontracts with somebody to be part of their responsible goals or so forth, that they're responsible for administering the contract, and they're ultimately responsible, just as Chomp contracts with physicians to provide services in their ER, it's the same thing. That you are ultimately responsible for the care, however your contract is for the subcontractors.
I understand that, but what I'm saying is if other people don't, maybe just a line that defines it might be beneficial, is all I'm saying.
For lay people, yeah.
Right,
Yeah,
and
or
as a
for people that are
subcontractor-
looking at this and may not understand.
Right, and is the subcontractor do their own collections and billing, or is it gonna happen through?
That's up
Right,
to
right.
however the provider contracts, right? That it's completely flexible as to what the contractor or the provider wants to have, and there's their contract with the subcontractor. But we could probably put a sentence in there that explains that.
Carlos Vega, Division Chief, Rate of Fire. Comment on the section 5.11.1.1. It mentions systems already at phase 2, the TDVA digital. So it should be required, not an option, that we have the communication.
Could you repeat that?
So yeah, so it mentions the digital, the TDVA. So as far as communications go, that gives it an option that their raters are able to upgrade to that. It should be a requirement. We're already at that level, match the county as far as communications go. And it's up to you. We also go echo the standby time. That should definitely be modified and changed. She also mentioned having the ambulance providers be required to attend PFP ops and a little bit. That's part of that.
How do you?
Participate in PFP and operations committees for the county committees.
And on language, on things like that, there's usually language in the scope of work or in the agreement that allows us to require, if there's a system upgrade, then that is the thing that is done. If we ask the provider, then let's say we put together a brand new committee, then we can ask the provider to participate in that. Because we can anticipate that kind of change in the future. That we don't do that. And I'm sorry, because I have a hard time hearing your voice. I don't know. So if I'm not.
So yeah, we'll
speaking to
be
what
like
you said.
operations and kind of any kind of committee that has to do with working with one another, kind of working together. So it should be a part of that. I think it would be good to kind of spell that out, make sure that they should be participating. I mean, AMR does now, they're part of those, but I think just continuing that.
Yeah. And that comes with us just saying to the provider, we need you here, right? There's this committee or there's this activity that we need you there. So because we're not going to be able to anticipate every change that might happen in the future.
Other comments, anything coming from online? Other comments?
Yeah, I had a couple of things. It's been a little bit, Dr. Clancy, since you talked about the 5150. So I just want to correct me if I'm wrong, but when what you were talking about, are you talking about possibly having something like a psych units that could go directly from the scene to an appropriate facility, or were you talking about something different than that?
Well, I think that there's a number of options that can be quite robust and be geared more towards mental health. I actually don't think it's the contractor's responsibility. I think it's the entire county's mental health program's responsibility to design this and implement it. And what I'm hesitant with the language is, you know, right now, the way the system is designed is it's heavily reliant upon ambulance transport. And I think if we think that it's inhumane, we need to make it humane, number one. I think we need to recognize that our goal is that these are truly the highest risk of medical patients. You know, a suicidal patient in a crisis emergency, that's a huge mortality rate, right? And you guys, if we give you the expertise and the tools to intervene, it's just as important as when you give nitroglycerin to chest pain, if not more. Actually, your number needed to treat is probably far better on this one than it is to make a difference, because nitro doesn't really help that much. But anyways, I'm off track. So I think that the county is responsible for implementing systems to appropriately care for these people, right? And our RFP should guide that the EMS, whoever the contractor is, will support those processes that are established within the county to provide this level of service. But I think to say, and this is one issue that I have, and I'll send it in my comments, you know, you have a lot of language that says, try to do BLS, try to do BLS, try to do BLS. Well, it's the responsibility of the transferring physician to determine the level of care and support. What you really should say is build a system that allows you to have multiple levels available, but transport the patient based on the requirements of their transferring physician. And, you know, I think the same thing holds for if I can't keep a patient in my facility, that patient is going to be a huge flight risk in the back of wherever they are, right? And they're a huge risk. The transition of care is your highest risk time for a patient to escalate or decompensate. They can be stable for 12 hours and have no issues. And you put them in the back of the rig and now they're trying to escape. And, you know, having the ability to have sedation, medications and things like that becomes critical. A BLS ambulance would be put in a very difficult, very unsafe situation potentially. And these are unpredictable people, or they wouldn't be going for a locked facility. So I don't have, a crisis unit within the county would be amazing. But we can't build an RFP around something that doesn't exist. But we can rely on a contractor to build something that the county should have built. So I think we need the RFP to allow innovation and flexibility, but also require it to meet the needs of the system so that I don't have people living in my emergency department. And they are truly living there.
Kolinsky, just to say, you said that we use the word inhumane or something, and please give us.
You did, and I'd like it out of there.
What I'm saying is that please give us the benefit of the doubt, because we are human. And
No,
could
I
be
got
just
it.
A typo or just in this have to
I
happen.
think it was meant in the right way, but I think to say that I think to say that your ambulance is inhumane kind of says, really? Then we need to fix that.
Well, maybe we need to rephrase that.
We do.
because Let me.
And I'll send it to you. And I know you guys will want to fix some of this because some of it is just like definitions, right? I actually didn't read it. Thank you, Philip. Philip, I read it and said, oh, these definitions don't match. And I'm like, I could not go through that many definitions. You read those. And then when I found it, I was like, you know, we need to do better and we can do better. And I trust that you guys will want to when you see this, and we want to make the system amazing. And that's why I'm kind of passionate about it. So sorry.
And we are sensitive to the needs, and we want to be responsive to the needs of the system. And in particular, you know, you're speaking about a very high risk.
Traditionally marginalized, right?
Yes.
All of medicine. I mean, we wouldn't even insure these patients with parity, right? It's like, oh, you can have regular medical care and we'll only give you minimal coverage for your mental health or substance use issues, right? We're finally growing and learning. I think we all need to do better.
Okay, so, thank you. I do think that the psych issue is important in this county, and it definitely needs to be dealt with. I don't think that there's any medic or EMT that has worked for any significant amount of time that has not either been injured or come that close to being injured transporting these patients. And so there's a lot that needs to be done, but having units that are specifically trained and personnel specifically trained to deal with these types of patients, I think is something that needs to be looked at. Also, I know a lot of people have talked about employee retention. And I think it's extremely important that language be placed in there to support these employees. I lived through it, losing my job and having to be rehired. And basically what it told me at the time is that the county did not value me. It didn't value my coworkers. It didn't value our experience. And I think the last thing you ever want to see is a new company come in here with 60, 70, 80% new employees. That's, I think, is a recipe for quite a circus. And then also, as far as South County, when I started in 1983, we had actually 4 ambulances down there. We had 2 primary ambulances, Soledad, King City, and then we had backup units. And yes, they did have 20 minutes to get their wheels rolling, but and usually it was shorter time than that. But we actually had more unit hours down there than we have today. We still have a unit in King City and a unit in Soledad, and I can't imagine that the call volume has gone down. I'm assuming it's only gone up. So I'd like to at least have that looked into as far as unit hours and what should be required down there. And if it's needed or not. I think that the prison is a city in itself. And there's tremendous unit hours that are used by the prison. And the prison, I haven't seen them step up and do anything. Maybe it's time for the prison to step up and maybe contract or do something to help either facilitate more unit hours down there, or have contract and have their own unit. And you got all these people paying taxes down there for a unit, and then it's not there, and it's coming from Salinas because you got two units at the prison. So that's something I'd like to see about that.
So it's kind of creating an inequity, basically having all the unit hours spent at the prison versus serving the citizens of South County.
Yes, and I can definitely be corrected. The prison may pay something into this. I just have never heard of it or seen it. And so, it's something that I think is needed to be looked at for a long time. And I don't think that the responsibility needs to be on the provider when it comes to the prison. The prison needs to be willing to work with the provider to help support more hours down there.
There's one section, I think it's 5.4.13 that deals with kind of the contractor's requirement to review call volume and response times. And you guys have that at every 4 years. That seems like a really incredibly long time to be looking at that.
Or upon request. Or upon request.
Right, but that seems like something that if I were looking at a system, I would want that to be a continuous goal, right? That this should be something ongoing that you guys are looking at on a regular basis and determining, and I'm sure AMR probably is, but as a county writing for the RFP and asking what my contractor does, I mean, I know AMR does, but I would think that you guys would want a more robust response from your contractors to say, hey, I'm continuously evaluating this and I'll divert resources if a call volume's higher in a given area. I'm not going to take every 4 years to do it. Kind of system response.
But that's why we left it there, or upon request, and it is an ongoing, just like we measure.
But that means you have to formally ask. Would you not want the contractor? It seems to me that you'd want the contractor doing this, a continual assessment and placing resources to meet the response needs. I don't know.
Well, that happens in their plan. They're constantly moving units based on the demands of the system.
Right.
And correct me if I'm wrong, Michael.
Yeah, and we have a lot of triggers in our system as well. Like in our case, we have a national and local analytics team.
Right.
So if they're looking at our numbers, or they even look at our response times to see any extremes, that will actually usually initiate another demand analysis, if you will.
Right, but from a county perspective, that's not what the RFP says. If you're doing it, But that's not what the RFP that you're asking for proposals that aren't AMR actually says or asks for. I mean, I would think you wouldn't want to go down from what you're currently having. But I think you at least want to model it off of what is currently happening. Every 4 years just seems like an incredibly long time to me when I saw that. Or upon request, I get it, it's there, you can ask for it, but I would think you'd want it on a system where it's kind of continuous.
Yeah, and that's the thing that we do have in the scope of work is the flexibility to change any of the reporting requirements that the EMS agency has the ability to change any of that. We started with, we did plug in 4 years. We thank you for your feedback. It is something that we can revisit, but what we do have is that we can add reports, take away reports, change reports, add frequency, change frequency. We have the ability to do that. There's language in because we even do that today. But thank you, we appreciate it.
Okay. Any other comments?
If I can make just one more statement. One of the things, I don't want to create any conflicts of interest for myself, obviously, since we're the current provider. But I would like to make a statement, to all of the stakeholders that, we would also like to make ourselves available, not necessarily to provide opinions of the scope of work or the RFP. But I'm always happy to have discussions with people and explaining some of the complexities of the system. And I think that not to make excuses, but we have been living it obviously for many, many years. There was a failure here in in 2006 with that contract. And I think that we can at least give you some perspectives on the challenges. CCT is a great example where I think it's a fair statement that, it operates at a significant loss. And it's very challenged having, 200 and some odd calls a year when you're, less than a call a day. There's a lot of different ways, and certainly we should always be making efforts to improve. I think that we also have a lot to offer in terms of perspectives and at least giving some insight to some of the challenges that we face in all of the aspects with, IFTs, behavioral health transfers, and it's amazing for me because I've been in a lot of different systems. I came from, Alameda County when there was the failure up in Santa Clara. I was asked to go up there for 3 years, and I will say this, and I know that it's an extremely complex issue, especially when we have all of this geography. But there is really a great EMS system here. Like just having experienced the other systems, there's definitely a lot of room for improvement. But specifically, I live in some of the other areas that I oversee today, where it's hard for them to get any CCT resources when it's not part of the contract. So there's a lot of different things that we can look at to improve. But I just wanted to kind of make the statement that I would always be available to answer questions, to give some of our insights to what we see, in our experiences today in those services.
Thanks, Mike. And I think a lot's been said, and I appreciate all the input that everyone brought to the table. It's, as you can appreciate, it's an incredibly complicated thing to move forward, to keep everyone happy, to try to build as much equity into the system as possible, to meet all the needs of the system from EMS to patients to hospitals, and also to have enough resources, but to be affordable to the citizens. And so that's a huge challenge as well. Ideally, as Teresa mentioned, we'd like to have an ambulance on every corner. That would be the best, but it's just not affordable. It's not practical. And even if the county had all the money in the world, staffing, and units. And so there are limitations, real life practical limitations to the ability to deliver every single thing that's desired. And so what the EMS agency is trying to do is balance all those things. And we're not going to get it all right 100% of the time. And that's why we value the input. I know that, it gets frustrating sometimes, but the ultimate goal is to have the best EMS system that we can have, and have one that's affordable to patients, have one that's accessible, and have one that meets the needs of all the stakeholders. So thank you for all of your input. We really do appreciate it, and we'll take this back and have a lot of internal discussions and dialogue, and see what we can do moving forward.
Okay. We're gonna go ahead and close out portion of the meeting and move on to announcements or anything for the good of the order. It's like we're all talked out. Going to the next meeting, and this is for the EMCC, is Wednesday, January 10th at 2024, 10:30 a.m. With that, we'll go ahead and we'll close the EMCC meeting. I don't know if the chairs of the other committees want to close theirs, but the EMCC meeting is officially closed.